Welcome everyone to the Buncke Clinic Virtual Visiting Professor Series. On behalf of all my partners here at the Buncke Clinic, I am delighted this afternoon or evening to welcome our dear friend, Dr. Jeff Yao from Stanford. As we all know, Dr. Yao is Professor of Orthopedic Surgery at the Stanford University School of Medicine, and he is also the Director of the Hand and Upper Extremity Surgery Fellowship within the Department of Orthopedic Surgery at Stanford. Dr. Yao has many, many accomplishments, but in the interest of time, I'm just going to highlight a couple of them. As we also know, Dr. Yao was the Sterling Bonnell Fellow of the American Society for Surgery of the Hand in 2016. This is an extremely competitive honor to get, and the list reads like a who's who of hand surgery. And as we'll see in this talk, there's a good reason that Dr. Yao was given this honor. He was the program co-chair of the Hand Society back in 2019 when Dr. Jim Chang was the president. And he is also a founding member of the Manus National Hand Surgery Society, which is a great hand society. And he was kind enough to actually invite me to be a member of this society as well. And it's been a lot of fun. Dr. Yao is a reviewer for many journals, as you can see here. So his expertise is highly sought after, for everything from Annals of Plastic Surgery to Hand to JHS, Journal of Bone and Joint Surgery, Tissue Engineering, and so on. He has been a guest editor for Current Orthopedic Practice as well as Hand Clinics, and he is a deputy editor of Hand. I've gotten to know Dr. Jeff Yao very well over the last few years since he's been at Stanford. This is through our connections with Stanford as faculty, but also at meetings. And it's been a lot of fun. And I've discovered that we have many things in common and many interests in common. And one of them, which is a kind of an inside story, is our love of dumplings. And this is Din Tai Fung. And we discovered in Sydney, Australia, that we both really, really love these dumplings. And so we went there at least 2 or 3 times during that trip. And we did a lot of damage. And it's become an inside joke. And so whenever Jeff goes to Din Tai Fung, he sends me a picture, and this is him with his wonderful wife, Jen. And whenever I go to Din Tai Fung, like this in Taipei, I send him photos as well. So it's kind of a bit of a running joke. As I mentioned, Jeff is a founding member of Manus. This has been a lot of fun to be part of Manus. He's quite an enthusiastic person within Manus, and he really is kind of the main cheerleader. One thing I did discover, Jeff is better at many things than me, and one of those many things is axe throwing. He's quite the ace. And I think he definitely beat everyone who was playing that day. So he's not only a fantastic surgeon, but a masterful axe thrower. Jeff, thanks again for being with us. It's really a pleasure to have you, and we're really looking forward to hearing about your tips and tricks in hand and wrist arthroscopy. And I'm going to find you in the list here and make you the presenter. All right, you should be able to share your desktop with us now.
All right. Can you hear me okay?
Yep, I can hear you, and I can see the slides, or your desktop rather.
Awesome.
Perfect.
Gosh, I got to climb out of that hole now. Thanks, I appreciate that. Very nice introduction. Those nice embarrassing slides, but no, we certainly have the relationship where we can joke with each other, and it's something I truly cherish. I really want to thank you for the opportunity and really the honor to participate in what I think is a fantastic lecture series that you folks have put together. I have the utmost respect for Greg, Rudy, Bobak, Andrew. It's a fantastic clinic, the Buncke Clinic, but also this lecture series. I've been very impressed with the number of faculty, world-class faculty that you have speaking. Is just amazing. You kind of slummed it a little bit with today's speaker, but I am honored to be part of it. So I've been tasked to talk about tips and tricks of hand and wrist arthroscopy. I know we have a bit of a diverse audience today, plastic surgeons, hand surgeons, orthopedic surgeons. So I know not everyone is familiar or uses wrist arthroscopy in their daily practice. So I wanted to sort of focus on not necessarily the more esoteric things that maybe if you're just new to arthroscopy, you wouldn't necessarily use in your daily practice, but really focus on the things that I think are, in my practice, are done almost weekly in terms of arthroscopy. My top sort of indications for wrist arthroscopy. This is my disclosure slide. Another disclosure I have is that I'm a member of the Babak Safa fan club. Babak took a little bit of my thunder a little bit in showing some funny slides, but you know, it's been really a great honor to and pleasure to get to know Babak. I met him when I first arrived at Stanford about 15 years ago when he was a chief resident in plastic surgery, and it was great to see him go on to the prestigious Buncke clinic and stay there, and just really to watch his career grow has really been a great sight. As we all know, he's a world-renowned microsurgeon, and you know, he's done really impressive things. In fact, he's literally the poster child for the American Society for Surgery of the Hand. This is no joke. If you go to the American Society for Surgery of the Hand, ASSH.org website, the first picture you'll encounter is Babak Safa in the operating room. So he is literally the poster child for our hand society. That's how much we think. That's how high of a regard we think of Babak. Some more axe throwing slides. You've seen these, but this is in the days when I kept my hair. But you can see Babak is very focused, and I like to say that not only is he a fantastic microsurgeon, but he's also a great macrosurgeon using devices such as these. And you can see he's winding up, and you can see the result from one of his throws. It may or may not have been.
I don't think that was mine. That was probably yours.
All right, so this is where I'm from, Stanford University. There's my email address. If anyone has any questions, feel free to email me or ask me at the end of the talk. I'm happy to answer any and all questions. Okay, so let's talk about wrist arthroscopy now. Hang on one second. Some of my slides are obscured by this.
Yeah, you can minimize that actually. There's, I believe, two arrows that are pointing at each other kind of obliquely. If you click on that, got it? Okay, great.
Yeah, thanks. Okay, so arthroscopy of the hand and wrist has been around for about 4 decades, really popularized in the 80s, and the indications have really grown in the past 4 decades. It initially started as just a diagnostic thing, and we know that it's more accurate to identify pathology than CT scan, MRI, and even arthrography. And where the growth has really been is in terms of the therapeutic indications. And we know that we can use smaller incisions, less soft tissue dissection, less devascularization of our tissues, earlier recovery, earlier return to work potentially, and greater patient satisfaction. So these are just a short list of the therapeutic indications that you can use arthroscopy for in the hand and wrist, and you can see it's a long list. There's a lot of things that we can use it for, including some of the more esoteric things such as salvage procedures, arthroscopic PRC, distal scaphoid excision, four-corner fusion, treatment of distal radius fractures, scaphoid non-unions. But again, for the purpose of this discussion, I want to focus on kind of the more run-of-the-mill type things, because I know a lot of us in the audience aren't going to jump and do a arthroscopic distal scaphoid excision four-corner fusion, but you might do some of the other techniques on this list. So the question becomes, when you get to do some of these things, is it a triumph of technology over reason? And for some of these indications, maybe you can make that argument. But in my mind, the current best indications for arthroscopy are these. I think if you're new to arthroscopy, and you want to start treating patients with arthroscopy, these are in my mind, the top 5 or 6 indications for the use of arthroscopy, and it's been shown time and again that these are good indications for that. And so this will be kind of a sort of a around the world type of discussion about multiple different pathologies. So bear with me here. I'll be switching gears back and forth, but we'll basically talk about, again, my top indications for arthroscopy. And I'll try to share with you my best tips and tricks for these more, I don't want to say mundane, but more, you know, run-of-the-mill arthroscopic procedures. So diagnostic arthroscopy is very helpful in my practice. When the MRI is not necessarily agreeing with the physical exam. The radial carpal portals, they're named after the dorsal wrist compartments around which they are made. So for example, the 3-4 portal is made directly between the 3rd and 4th compartments. And my first tip is really create your portals carefully. For the orthopedists in the audience, some people are familiar with knee arthroscopy or shoulder arthroscopy. You don't want to just plunge the knife in when you're creating your portals. Remember, there's a number of important structures directly below the skin. So I basically just make a small nick in the skin and use a curved clamp and just spread down through the soft tissues until I get to the capsule and then enter the capsule. So really be careful about creating your portals. These are the mid-carpal portals, and again, they're named basically based on their location. And I won't belabor the point and talk about all the portals in detail, but suffice it to say there's a number of different access points for not only your arthroscope, but also your instruments to gain access to the nooks and crannies of the wrist. My second tip is use your accessory portals liberally. Don't pigeonhole yourself into the major portals that we use in every case. These are other portals that are very powerful to increase your access, your visualization, and your ability to treat certain pathology within the wrist. My next tip is what I like to call the poor man's arthrogram. We published on this a few years ago. Basically, when you first start with your arthroscopy, especially if you're using water or fluid for your arthroscopy, is inject and insufflate the joint. And the reason that's useful is because, number one, when the joint capsule blows up like a balloon, it makes it easier for you to establish your portal. Number two, it's like I like to call it a poor man's arthrogram. If we inject fluid into the radial carpal joint via the 3-4 portal, we know that the radial carpal joint, based on this study, should take about 3.5 milliliters of fluid. So if you're injecting and you feel you're going past 5 cc, 6 cc, 7 cc's, then you know that there's some communication between the radial carpal joint and either the mid-carpal joint or the distal radial ulnar joint, or both. And so that helps you kind of confirm your diagnosis if you have an intercarpal ligament injury or a Tfcc injury. My next tip, I like to say that before you get started, be like a pilot. You know, pilots have pre-flight checklists before they take off. They need to make sure they check off all these things and do all these things that may seem mundane, but it's kind of like doing your timeout when you're doing a surgical procedure. So before you start anything, and this is classic when our residents and fellows get into the joint, they just want to start going everywhere and looking everywhere. So, but you got to be sure that all your instruments are ready. You want to make sure that the scope is white balance, you have your focus, your inflow, if you use inflow, and outflow. Tip number 5, always follow the same sequence. So I basically make sure that I see all these ligaments in sequence and take photos of each one. That way I know that I won't miss something. And I know that 10 years down the road, if I'm looking at a set of photographs from a case I did 10 years ago, I can know that the 3rd photo is this structure, the 6th photo is that structure, et cetera, et cetera. So it helps to have that routine. Okay, so standard radial carpal arthroscopy. Here you can see I like to use fluid. I know a lot of the faculty around the world like to use dry arthroscopy, but I do like to use fluid. Here's the radioscapholunate ligament, also known as the ligament of Testu. That's sort of my lighthouse to the joint, and then we know that's going to lead directly to the scapholunate ligament, which I'm probing there, the scaphoid to the left, the lunate to the right. As I move more radially, here's the long radiolunate ligament, very stout ligament, the strongest ligament in the wrist. And then there's a space, and then the radioscaphocapitate ligament is directly radial to that. And the space is a space of Poirier, the weakest part of the capsule, and that's where the lunate can pop through in your lunate dislocation patients. As I move my scope more to the ulnar side, you see the lunate is now above, and those are the radioextrinsic ligaments. In the background, there's the lunate facet I'm pointing to now. Those are the ulnar extrinsic ligaments, the ulnar-lunate and ulnar-triquetral ligaments. And as I move my scope more ulnarly, there's the articular disc of the Tfcc. And this particular patient has some wear on the ulnar aspect, the periphery of the Tfcc right in there. You can see the synovitis. This patient has a peripheral Tfcc tear. So that's kind of our radial carpal arthroscopy from the 3-4 portal. This is the mid-carpal arthroscopy, and so we're one joint distal. So there's the capitate head above, and there's the lunate at about 3 o'clock, scaphoid about 9 o'clock, and the gap in between, that's the scapholunate interval. Normally that should be nice and tight, as you can see there. Later on in the talk, you'll see what a pathologic scapholunate interval should look like. As I bring my scope up distally, you can see that's the scapho trapezial trapezoid joint, or SCT joint. The trapezoid is to the right, and the trapezium was to the left. As I bring the scope back down between the scaphoid and capitate, now my needle is in there pointing to the lunate, and there's the capitate articulation. And now as I go more dorsally, you can see way in the background, I'm bringing the needle back there. That's the hamate back there. You can see there's a lot of synovitis in this particular patient. And you can see there's a second facet here of the lunate. This is called a type 2 lunate. So the second facet for the hamate, the proximal pole of the hamate. And at about 2 o'clock is the triquetrum. All right, so let's talk about different pathologies. So dorsal ganglions is one of my favorite procedures to do arthroscopically, because who wants this, a big keloided scar with via an open approach, when you can have this, these little poke holes? Patients love that. So arthroscopic excision of ganglions is not a new concept. It's been around for a while. I think the benefits are they're more cosmetic with earlier recovery. Although if you look at the one prospective randomized study of arthroscopic versus open ganglion excision, the outcomes are basically the same. I like it because I can look throughout the rest of the wrist. I can make sure that I avoid injury to the scapholunate ligament and make sure there's not any other articular pathology that can be a cause of a patient's symptoms. The key to arthroscopic and, quite frankly, open ganglion excisions is to make sure you identify and excise the stalk. We know that the recurrence rates when just excising the cyst were unacceptably high, up to 40%. So now that we know that we have to remove the stalk as it originates from the dorsal scapholunate ligament, the recurrence rates have dropped to under 10%. And the question is, how can you excise what you can't see? Sometimes you get in there and it just looks like a lot of schmutz, and it's very difficult to identify the actual stalk. If you look in the literature, you can see the stalk anywhere from 9% to 100%. That's the biggest spread that you can ever see. So I find that I could see the stalk reliably without any extra maneuvers, probably about 50 or 40% of the time. So this is our next tip, which is a paper we wrote a few years ago using a dye, indigo carmine or methylene blue, to inject into the ganglion percutaneously, and then that will help you identify the stalk arthroscopically. So here's the setup. We typically use the 6R portal to perform our diagnostic arthroscopy. The ganglion here marked out in red is usually directly underneath the 3-4 portal. So we start with the 6R portal and look over radially. And this is a video showing what it typically looks like. So I'm in the 6R portal. I'm looking radially. Lunate is in the foreground. Scapholunate ligament is here. Sorry, the volume's playing. Here's the scapholunate ligament. Here's the scaphoid. And if you follow the scapholunate ligament up, here it looks like that could be your stalk. But what we do is here it's you can clearly see the stalk. You see the translucency of the ganglion here emanating from scapholunate ligament. But just for illustrative purposes, you can see as we inject the dye, it lights up really nicely blue, and you can see everything that's blue here is the ganglion stalk plus the cyst itself. And what that really does is it helps guide your excision. So when you get in here, I apologize, these videos won't play, but essentially what this was showing was as I'm injecting, you can see it lights up blue, and then you get your shaver in there and just excise the stalk and the cyst directly off the scapholunate ligament. If you look carefully at this image, you can almost see the lumen of the stalk right here, and there's all the methylene blue that was injected. So it really helps you visualize that. Unfortunately, this video is not playing, but suffice it to say, it's basically showing us getting in there, sucking out the stalk and the cyst arthroscopically. And that's what it looks like when the cyst is excised. Postoperatively, I think this is another benefit. I basically put them in a soft bandage and let them basically use their hand normally, take out their sutures at 2 weeks, and then they're done. So we published on our experience with using the dye. We were able to visualize the stalk in all 27% of our 27 of our patients. we did have one recurrence, and this was a Kolk ganglion cyst where it wasn't readily palpable at the dorsal skin. So we found that it was difficult to palpate. So getting the injection into the cyst itself was difficult and not reliable. And we did have one recurrence with with that technique. No complications with injecting the dye. Moving on, this is kind of in the same spectrum, because if you think about a ganglion injuries, ganglion cysts are in essence a manifestation of an intercarpal ligament injury, usually the scapholunate ligament injury. And so let's talk about how we use arthroscopy to treat intercarpal ligament injuries. So my next tip is what I call the bubble test. And unfortunately, this video is not going to play either, but basically what this is showing is the needle in the midcarpal joint. And what I do is I inject air within the midcarpal joint, and I have my scope. I put my scope in the radiocarpal joint. If I inject air into the midcarpal joint and I look from the radiocarpal joint, I see bubbles passing through either the scapholunate ligament or the lunatotriquetral ligament, then I know that there's some insufficiency there. So that's a nice way to identify a partial ligament injury if it's not quite visible. So that's a nice test to do. Our arthroscopic treatment is based on the Geisler classification. And so the Geisler classification is based on the amount of instability of the intercarpal ligament, either the scapholunate or lunatotriquetral ligaments, based on the findings from the midcarpal joint. And you can see that for the earlier stages, debridement with thermal shrinkage of the ligament is very useful. As we get to stage 2 and stage 3, then we'll also often add pinning. And then when stage 4, or the so-called complete drive-through sign, then the ligament's completely incompetent, and then we have to talk about an actual repair. So just a quick word on shrinkage, because this gets a bad rap in the orthopedic literature, primarily because it's used when it was used for shoulder instability, these patients failed miserably. In the wrist, however, it actually works very well, and I'll share with you some literature later on, but it's a very effective way of treating these intercarpal ligament injuries that are not completely torn. So this is my next tip, is to use the thermal shrinkage. The way this works is it restores stability by tightening the ligament. I tell people it's sort of like having a piece of meat and you put it on the grill, and what happens is the meat shrinks, right? It's the collagen will shrink, and I'll show you why that happens. And we also think that there's a element of denervation, which also helps in terms of these patients getting pain relief. So why does this happen? So if we remember back from medical school, type 1 collagen is made up of collagen fibrils, which are linked together in a triple helix, and they're linked by covalent bonds. And these bonds are two types: the heat labile bonds and the heat stable bonds. And this is from the sports medicine literature of the orthopedic sports medicine literature. So what happens is when the tissue, the collagen, is treated thermally, it breaks the heat labile bonds, but the heat stable bonds are still intact. And so there's a net shrinkage or net shortening of the collagen fiber. And then over time, over the next 6 weeks or so, those heat labile bonds reconstitute themselves, and overall, the collagen regains its original strength. And so that's why the tissue shrinks. In our lab, we showed that we think there's also a denervation effect of this thermal treatment, as we showed with using the thermal treatment, that it led to a obliteration of neuronal markers in that tissue. Now, we don't know if this is a long-lasting effect. It probably isn't a long-lasting effect. There probably is some element of reinnervation as time goes on, but at least in the short term, this sort of helps, in my mind, sort of explain why these patients get better. So this is what a typical volar scapholunate ligament would look like after it's been thermally treated. And so here's some more examples of that. And when it gets larger, when it gets more severe of a injury to the ligament, then Geisler grade 3 we're talking about, then additional pins may be necessary to help stabilize the interval. And that's going to be shown here. As you can see before, I could get my probe in there. I can spread open the scaphoid and lunate apart from each other. You can see the volar scapholunate ligament is hyperemic and synovitic down in the front, down in this area. And then after we've pinned the joint, so that's stable, and we've tightened the ligament. So over time, over those 6 weeks, that will slowly mature. So what are the results? So there's a number of studies, most of these retrospective, shorter term follow-up to around 2-year follow-up, and all quite good outcomes. This probably has the longest follow-up prior to our study, which I'll show you in a moment, with about 4-year follow-up. And again, these patients treated with thermal shrinkage had very good outcomes. In fact, we published this last year on 9 of our patients treated with a mean 7-year follow-up. You can see all their outcomes measures are quite good. And most importantly, 0 of these patients needed subsequent surgery. Now remember, these are patients with chronic dorsal central wrist pain. It wasn't getting better. They couldn't do yoga, push-ups, gymnastics, etc. They were unhappy. They had this procedure, and they were able to return to those activities without having any subsequent surgery. For the higher grade injuries, grade 3 and even potentially grade 4, this is a relatively new technique. It's gaining popularity. It's described by Christoph Matulin to perform a dorsal capsule ligamentous repair or capsulodesis of the ligament. And at first glance, this looks a little bit unbelievable that this will actually work. But now that I've done it in many patients, I'll tell you, I'm a believer that I really do think this works. And I'll show you a patient of mine. But essentially what this is doing is not only stabilizing the scapholunate interval, but also performing a capsulodesis of the dorsal capsule down to the scapholunate ligament to provide extra stability and to prevent dorsal subluxation of the proximal scaphoid. So here's one of my patients. You can see there's a nice gap between the scaphoid and lunate. You compare that to that initial mid-carpal arthroscopy I showed you, that diagnostic arthroscopy where it was a nice tight articulation between the 2 bones. Here, you can see the gap is there, suggestive of a high-grade ligament injury. And so this is a video showing basically from the 3-4 portal, I'm introducing the needle through the remaining scapholunate ligament and introducing it from the radial carpal joint to the mid-carpal joint. Now with my scope in the mid-carpal joint, I'm harvesting the sutures from these 2 needles. Then we pull the 2 sutures out, tie a knot, and pull that knot intra-articular, and you can see it's sitting on the dorsal scapholunate ligament in the bottom right photo. So here's a video that sort of helped us show that in more detail. So the video got truncated a little bit, but you can see that after the knot was tied, I'm pulling on that, and that's securing that dorsal aspect. And now what's happening is we're tying the knot dorsally to cinch the capsule down to the dorsal scapholunate ligament to further stabilize this. And so you can see before, when I stick my probe in there, it's pretty open. And then after, you can see I can't get my probe in there. I'm sorry, this video was supposed to play a little bit more. Let's see if, oh yeah, okay. So now you can see I'm opening the joint here. This is before I put tension on the sutures. And then once I pull my probe out and put tension on the sutures, you'll see it'll tighten up. Right there, you can see that gap close, and then I can't get my probe back in there. So it's a very powerful, surprisingly powerful technique. So I highly recommend checking it out if you're doing these things. Okay, so again, we're kind of taking a whirlwind tour around the wrist. So now moving on to the Tfcc, which probably, when you're talking about wrist arthroscopy, is wrist arthroscopy 101. I mean, this is probably the #1 most common indication for doing wrist arthroscopy is taking care of Tfcc injuries. They're ubiquitous, and it's an easy way to get experience doing arthroscopy. So remember, Palmer classified these ligament injuries of the Tfcc in terms of traumatic and degenerative, and he subclassified the traumatic injuries based on their location. And for the most part, for central, volar, and radial tears, we basically debride the ligament. When we get to the ulnar aspect or the periphery, that's when we talk about repairing. And the reason we talk about that is because the periphery of the Tfcc is highly vascularized, as you can see with these dye studies. And so those are most amenable to healing. Therefore, those are the ones we repair. And there's a number of different treatment options that have been described for treating capsular tears of the Tfcc. Certain techniques do have disadvantages, including some of these large suture knots that can be underneath the ulnar skin. They can be painful for patients, or you can tie these over buttons, but that could be painful and unsightly for patients as well. There's also the potential for injury to the dorsal branch of the ulnar nerve. And there's the presumed thought that these monofilament sutures might not have a significant knot security, and the concern is that you have a weaker repair. So this is my next tip. This is a technique that I currently use. This is a device that was initially described for knee meniscal injury repairs. And I thought to myself, well, you know, the Tfcc is almost an analogous structure in the wrist as the meniscus is to the knee. And so we thought, why don't we try to use this device to repair Tfcc injuries? And what this is it's a introducer needle with two PEEK blocks with a pre-tied suture in between. So the needle is passed through the tear and then out through the ulnar capsule and deployed, and it flips around and catches on the ulnar capsule. And then we put another block on the other side of the tear, so it makes a vertical mattress configuration. And once that flips on the other side of the capsule, then we just pull on the suture, and it's a pre-tied suture, so it pulls on the suture and that brings the tear together. So it's a really simple technique. And we described this technique, and we've shown it to be biomechanically strong and safe. In the interest of time, I'll skip through some of these slides, but basically it shows that the implants were placed safely away from the ulnar nerve and the dorsal branch of the ulnar nerve. Biomechanically, we also showed in an Instron MTS that this repair is significantly stronger than a traditional Whipple-Geisler 2.0 PDS type repair. And so we described this technique, and basically these are standard portals that you would use for any arthroscopy. And in this case, we'll use our 6R portal as the viewing portal and the 3-4 portal as our instrumentation portal. And so here you can see the scope in the 6R and the instruments coming in the 3-4. This is a cadaver. This is a patient, and you can see the scope is, the scope is in the 4-5 portal in this particular case. And you can see the instrument, I'm visualizing the tear, which is right there. The capsule, ulnar capsule, is out of the picture to the left. So I march my needle back about 2 millimeters away from the edge of the tear. I pop through the articular disc. You can see this is an unedited video. And once you're through the articular disc and then through the ulnar capsule, you deploy the first block, and it flips around on the ulnar side of the capsule. Then we come on the other side of the tear, so this creates a vertical mattress configuration. And this, I'm just popping through the ulnar capsule. And then there's a trigger device on the handle of the device that deploys the anchor. And then we pull out our introducer needle, and you can see we're just pulling on the suture. And as we pull on that suture, that's pulling the articular disc back over to the ulnar capsule, and that helps stabilize that. It's very fast, easy to do, and very strong. You can see it tightening up. So here's pre-repair. You can see it's the trampoline effect is lost. There's a soggy articular disc, and then post-repair, you can see on the right, you can see the amount of tension that's been restored to this articular disc. You can see it's got a nice trampoline bouncy effect, and you can see it's nice and stable. So we published on this, and suffice it to say that the outcomes were great, 92% good to excellent subjective outcomes. Meantime, the full activity was about 5 months, and we had 0 complications with this technique. We followed this up in 2019 with mean 7-year follow-up, and again, great results. So the benefits of this technique are its ease of use, it's fast, you don't have those prominent suture knots on the ulnar aspect of the wrist that bother the skin, no extra incisions. We showed it to be safe in the lab. And I think the major improvement is the strength of the repair, because historically we would immobilize our patients in a sugar tong splint for 6 weeks, 4 to 6 weeks. With this, now I basically put my patients in the short arm splint for 2 weeks, and then they start therapy. So that greatly enhances their quality of life. Moving on to ulnar impaction syndrome, kind of in the same realm. Here you can see a classic patient with edema within the triquetrum and lunate, secondary to ulnar impaction. We know that the standard treatment techniques are a wafer procedure, also an ulnar shortening osteotomy procedure, but I would submit to you food for thought. Microfracture is a nice technique that we stumbled upon. It's the first line of treatment for chondral lesions in the hip, knee, and ankle, but until recently there were no reports of its use in the wrist. And the way it works is basically you have your osteochondral defect in your lunate or triquetrum from the ulna banging up against it, and so the articular or hyaline cartilage is gone, and there's really no regenerative capability of that cartilage. And so basically what you do is you take a shaver or a curette to remove the subchondral plate and subchondral bone, and then we perform microfracture. We fracture the subchondral plate where it's kind of like breaking the top of the creme brulee. And what that does is it exposes the underlying cancellous bone, and the cancellous bone will then allow the blood to egress out and form a clot, and that clot will over time mature into not articular cartilage but fiber cartilage and resurface that articular defect. So it's sort of like having a big pothole in the street. We can fill it with blacktop. It's not quite the same as when it was originally laid down, but it's a lot better than having that big pothole there. And so here's this is my next tip. And so there's a classic example of an ulnar impaction lesion viewing from the 6R portal of the lunate. You can see the delaminated cartilage. You can see the exposed subchondral bone. So we debride the cartilage and expose the subchondral plate. And these are microfracture awls that we use to sort of break through the subchondral plate. You can see it before and after the insertion. And then once you pop through, I turn off the fluid, and you can see that the blood starts to come out and form a clot, a hematoma, on to cover or resurface that osteochondral defect. And there you can see it there. At this point, it becomes a little controversial. Some authors recommend early motion. I prefer to immobilize because I'm worried about the shear forces on that hematoma, causing it to avulse from the defect. So I like to immobilize for 6 weeks, and then we start range of motion exercises. And I had the opportunity to take one of our patients back about 5 years later. She had this unrelated issue, so I took the opportunity to go ahead and look at that. And you can see pre-microfracture, you can see the big defect. Post-microfracture 5 years later, you can see it's not by any means articular cartilage, but it's resurfaced, and that's a lot better than having that big defect there. And we published on our experience of 7 patients using this technique, and their dash scores in PRWE were better, not normal by any means, but they were certainly better. And most importantly, none of these patients needed a formal ulnar shortening osteotomy or other secondary procedure. So I think it's very useful, a useful technique. Okay, let's move on to the thumb now. So now I'll talk about my experience and my indication for thumb arthroscopy. We all know that there are many different methods of treating thumb CMC arthritis, most of them open. They all provide reliable relief of pain with variable improvements in range of motion and pinch strength. Meta-analysis favored just removing the bone-on-bone pain generator, or the so-called HDA procedure. So just removing the trapezium should be enough. But there is concern for these open procedures leading to a prolonged recovery. So that led to the advent of arthroscopic hemitrapeziectomy, now not removing the entire bone, but just removing, again, that bone-on-bone pain generator. This has been described since the mid-90s and been published on by a number of people ever since, with the potential of shorter recovery and no bridges are burned. So here's a classic example where the ST joint is still okay, but there's pretty bad CMC arthritis. This is the setup now. We have traction on the thumb, and we have our standard portals, the one radial, the one ulnar. Remember, our portals are named based on their location relative to the dorsal extensor compartments. And I like the thenar portal described by our colleagues at Brown, which is basically 90 degrees to the 1R and 1U portal. And this is what you'll typically see when you first enter in there. There's a lot of synovitis. And I want to reassure people who think, oh gosh, the thumb CMC joint, that must be so small to get into. Well, it's actually a very easy joint to enter as long as there's traction on the thumb. In fact, it's, in my opinion, an easier joint to enter than the midcarpal joint of the wrist, for example, because for the midcarpal joint, the capitate is sitting down into the lunate, very concentrically, and getting into that space is a lot more difficult, in my opinion, than getting into the CMC joint. There's a lot of space here. And so the first step is to clean out all that synovitis. Now this is a 3.5 millimeter shaver, and you can see how much space that this shaver has in there. There's probably about 6 or 7 millimeters of space in there. There's a lot of space. Once we remove the synovium, then we take a burr, and it's pretty simple. We just take away the distal 2 or 3 millimeters of the trapezium. It's really simple. My next tip is basically use a smaller burr and a larger sheath. And the reason I do that is because you can see sometimes when you're taking bone and debris away, it can clog the burr, and that gets really frustrating because you have to take it out, clean it out, put it back in, put it in there for 30 seconds, it gets clogged again, and you have to repeat that. So if you put a smaller, like a 2.9 millimeter burr and a 3.5 millimeter sheath, there's a lot more space for egress of a lot of that debris, and you'll clog it a lot less frequently. So I recommend doing this under fluoroscopic guidance. Make sure that you are not taking bone from the wrong, shaving away the wrong bone, which has happened. You want to prevent that, so make sure that you're in the correct joint. And this is what it would look like before and after a hemitrapeziectomy and pinning. Postoperatively with the pinning, these patients will be in a splint for 4 weeks, just like an HDA procedure. The pin's removed and then therapy's begun. And these patients did quite well. We published on this about a decade ago with good outcomes. And again, no bridges are burned. But as you know, a lot of people don't like having pins sticking out of their anywhere, particularly their thumb. So that led us to start playing around with this suture button construct. It's an internal device that helps suspend the thumb from the second metacarpal, much like a K-wire would, but it's implantable, so you don't have to wait at all to start motion. And so now this is what I typically do for all my patients, both arthroscopic and open. So here's what it would look like after we remove the hemitrapezium and we load the metacarpal. You could see that at time 0, the metacarpal will subside down to the remaining trapezium. That's not going to help the patient because that's going to be painful. So then we insert our suture button device, which is our next tip. And what that does is it prevents that subsidence of the thumb. And because it's immediate stability that's implanted, we can start motion right away. And this is what's been a game changer for me, is that our patients are immobilized for only about 5 days, and then we start range of motion at that point. They get a little splint for comfort and sleep, but otherwise they're moving it and using it for normal tasks. We published a couple of years ago on our midterm clinical experience, mean follow-up of about 5 years, and you can see the range of motion was restored, pinch strength and grip strength was restored. We did lose about 29% of the trapezial space height, meaning that instead of 100% of the trapezial height was maintained, only 71%. But again, that's okay as long as there isn't complete subsidence where the metacarpal is sitting on the remaining trapezium. As long as that bone-on-bone pain generator is removed, these patients do well clinically. Okay, so we'll round it out with how I like to treat STT arthritis, kind of like CMC arthritis. Isolated STT arthritis is not that common. Here's a typical patient. Often you'll see it in combination with CMC arthritis. In that case, I just do a complete trapeziectomy. But in this case, you can see the CMC joint looks pretty good, but the STT joint is pretty obliterated. This can be either post-traumatic, it could be idiopathic, it could be due to CPPD or pseudo-gout. And this is more typical wrist pain than thumb pain. Our treatment options are basically the same as other arthritic issues, as you can see here. Regarding surgical treatment, probably the most well-established, if you're not going to take out the trapezium, is to do an STT arthrodesis, which has been reported on by Kirk Watson and others to have excellent results. The problem is that even in the master's hand, Dr. Watson, there's about a 13% complication rate. It's not terrible, but not awesome. Other investigators, including Professor Minami from Hokkaido, Japan, has presented up to 30% complication rates, which is a little bit more sobering. And then Mark Garcia-Elias has talked about the distal scaphoid excision, and he talked about doing this open. These patients do well, but there is a question of developing a subclinical DZ, with no clear clinical sequelae. And in my opinion, I think this is a very valid option to do arthroscopically, but you need to make sure there's no sort of tendency of the lunate to be falling into extension preoperatively, because if there is, and you remove the distal scaphoid, then you release your scaphotrapezial ligaments, and then your entire proximal row will go into a DZ. Now, again, the clinical sequelae of that is unknown at this point, but that's something you want to try to avoid. So if the lunate is kicked back into a little bit of extension, I will favor a STT arthrodesis in those patients. So the question is, if you're going to do a distal scaphoid excision, can you do it arthroscopically? And you definitely can. This is an easy procedure to do. Here's that STT joint that we saw in my first video. And you can see that there's plenty of space here. You basically identify the distal pole of the scaphoid. You can see the paucity of articular cartilage on the adjacent trapezoid. Put your burr in there, just like we did for the thumb CMC joint, and just excise the distal pole of the scaphoid. And of course, you want to make sure you protect the capitate and don't burr into through the scaphocapitate joint into the capitate. You don't want to excise more than 3 millimeters of the distal scaphoid, because then you may destabilize it further by getting across the radioscaphocapitate ligament. And this is a typical patient where you could see before and after, you could see the space has been created. These patients are just immobilized for 14 days in a splint for comfort, and then they start therapy, compared to fusion, which is going to be casted for 4 weeks or more, and then it's a longer recovery. I think I have a couple more minutes. I'm just going to talk about kind of the complications of wrist arthroscopy. We published a systematic review of this a few years ago. Probably the most common complications are here. It's kind of most important is wrong indications. Make sure you're doing the procedure for the right indications, and that goes for anything. But other more esoteric and very rare complications with wrist arthroscopy are traction in arm position, establishment of the portals. That's super important, because probably the most common complication is an injury to one of the sensory nerves. So you want to make sure, as I indicated earlier, one of my earlier tips is to make sure you're careful about that. They're relatively uncommon. Again, a nerve injury is the most common complication. So if you do that spread technique, that'll keep you out of trouble. Remember, the joint spaces are small, so don't shove these instruments in and out of the joint, because you can definitely scrape up cartilage. Minimize the amount of duration of traction. Make sure your indications are chosen carefully. So to summarize my top 12 tricks for wrist arthroscopy: number 1, spread judiciously when creating your portals. Protect those nerves, protect those tendons. Use your accessory portals when needed, because they really help with your visualization. That poor man's arthrogram is a nice way to help confirm or deny your diagnosis. And remember, an arthroscopist is like a pilot. Have your pre-flight checklist and make sure you have everything ready before you start scoping. It'll make your life easier. I like to follow the same sequence for every scope. Make sure that you do not miss anything, and make sure that you know 20 years down the road what you're looking at when you're looking at some of these pictures. The color-aided visualization using indigo carmine or methylene blue for ganglions is really a game changer for me. It really helps me visualize it arthroscopically, and has really helped me confirm that I'm excising it completely. The bubble test can help diagnose your intercarpal ligament tears when you're injecting air, and you can visualize it passing through the ligaments. Thermal shrinkage is fine in wrist arthroscopy. I think it's very useful, and I'm a big fan of it for intercarpal ligament injuries. I showed my technique for arthroscopic Tfcc repair. The benefit here is you can start early range of motion as early as 2 weeks after surgery. Microfracture, you would consider for ulnar impaction syndrome. You can avoid ulnar shortening osteotomy for patients with isolated osteochondral lesions. When you're using a burr to burr away bone, use a smaller burr and a larger sleeve. That helps prevent clogging. And then lastly, I like to use a suture button suspension following arthroscopic hemitrapeziectomy. That allows for earlier range of motion as well. And so the question is, we've talked about a lot of different indications for wrist and hand arthroscopy. Is it a triumph of technology over reason? Here you can see this is a PIP arthroscopy. I wouldn't necessarily recommend this being done routinely. I think this is maybe a triumph of technology over reason, but hopefully I've discussed a number of different indications around the wrist that wrist arthroscopy is a very powerful tool, and I encourage you to add it to your armamentarium if it isn't there already. So with that, thank you very much, and happy, Bobak, to take any questions.
Great, thank you so much. Really a fantastic talk, and it really, I think it's a great talk for not just kind of beginners or folks who are new to wrist arthroscopy, but also people who have doing it for a while, to kind of fine tune some of the techniques, and especially with the tips and tricks that you were showing. I know that Andrew Watt does have a question, but I was going to just kind of start real quick with a question of my own, because you were talking about the indications. So just a very, very basic kind of question, and something that a lot of people see. In a distal radius fracture, obviously there are many that are very intra-articular. Can you tell us about your indications to do a distal radius fracture and do an arthroscopy to check your intra-articular alignment of bony fragments? How often do you do that? When do you do it, and when do you decide?
Yeah, that's a great question, Bobak. I purposely didn't include distal radius fractures because, again, I wanted to try to focus on the things that I think are the most useful for a beginning or intermediate arthroscopist. I think the use of arthroscopy for distal radius fracture fixation is very powerful, but it can be a little bit of a flail if you're kind of new to arthroscopy, and it's a great way to get frustrated if you don't know all the tricks to get your way around the wrist. And the reason that is because when you enter the wrist, it's usually a big bloodbath, right? You have a hemarthrosis, you have your fracture, hematoma within the joint. So you go in there and you can't see anything. And it takes time, diligence, and patience to clean that out. And then once you clean that out, then it's a very powerful tool for, in my mind, particularly you ask about indications. I use it almost every time I have a really bad dye punch or a depressed articular fragment. Obviously, you're not going to do it for your run-of-the-mill extra-articular distal radius fracture or something where the joint is relatively well reduced. You can, and in fact, that's not a bad way to sort of get some reps in and get used to it and get used to the technique. But in my hands, the best indications are those lunate volar facet or dorsal facet impression or impaction fractures, where you can get in there and basically get an elevator and elevate those fragments up. Because otherwise, if you're doing your standard volar approach with a locking plate, for example, to fix those fractures, you can't really identify that you're relying on independent reduction maneuvers. You're not visualizing that articular surface because you don't want to take down your volar radiocarpal ligaments.
Right.
And so there's been a number of studies that have shown that fluoroscopy alone, actually looking at taking a fluoroscopic view, saying, oh, that looks great, and then throwing the scope in and seeing, oh my goodness, it's not as good as I thought it was looked on fluoroscopy. So your reduction based on fluoroscopy isn't as reliable per se as under arthroscopy. Now, that being said, you can argue whether or not 1 millimeter step off on fluoroscopy that isn't visualized on fluoroscopy but is visualized on arthroscopy really makes a difference. It probably doesn't, and that's why you probably don't need to do arthroscopy in every distal radius fracture. But for those ones where it's depressed and you can't really elevate that up by manipulating the larger fragments around it, it's a very powerful tool.
You know, it kind of makes you wonder how many of your distal radiuses that look pretty good on fluoroscopy actually aren't as good as you think, right?
Yeah, exactly. And that's what
Yeah.
that study looked at. But again, it probably doesn't matter, right? I mean, a lot of them probably look great on fluoroscopy, may not look great on arthroscopy, but clinically, those patients probably just do just fine.
Right. Great. Thanks for that. Andrew, I know you have a question. Andrew Watt, are you on?
Yep.
Great.
So Jeff, fantastic talk. There are a couple of scenarios that I always struggle with in terms of wrist pain and particularly with wrist arthroscopy. So I'll ask you one at a time. One is radial-sided Tfcc tears. My experience with them, and whenever I talk to all my friends who do these, no one has a great solution other than go in, clean it up, and hope for the best. And at times I'll just say, go and clean it up, hope for the best, and then do an ulnar shortening. Do you have any other algorithm that you go through in your mind when you see on MRI that somebody has a radial-sided Tfcc tear, their DRUJ is completely stable, but they have pain?
Yep. So thanks, Andrew. That's a great question. You know, we did a study when I was a fellow in Philadelphia where we looked at the cohort of patients that either had a repair of a radial-sided tear or a debridement of the radial-sided tear. And so the reason it's controversial is because, you know, there's not a lot of good blood supply to the radial aspect of the TFCC. There's actually, it's really poor. And so the prevailing theory is that why are you even considering repairing it if the ability to heal is poor? And the thought is that if you take a burr and scuff up the sigmoid notch of the radius, that can create a bleeding bed that you can potentially reattach the radial TFC back down to by putting meniscal needles through it, drilling them through to the other side of the radius, and tying them over a knot over a bone bridge, tying a knot over a bone bridge on the radial side. Now, that's a lot of work. It's difficult to do. There's a huge learning curve. It's challenging. And most importantly, in this study that we did, granted, it was only one study, probably about, I think it was about 15 to 20 patients in each cohort. The outcomes were equal. The time was much less with the debridement, as you can imagine. The amount of therapy needed, much less for the debridement. Complications, less with the debridement. So basically, and again, the most important thing is the outcomes were equivalent. So to answer your question in a long-winded way, I just debride those. I favor debriding them and seeing how they do, unless they are particularly ulnar positive before we even start. And then I'll talk to them about the possibility that, okay, we'll go in and debride and shorten at the same time. But I still tend to favor debridement. And then as a backup down the road, if it doesn't work, then I'll go to a shortening osteotomy. But most of the time, debridement works very well, particularly if the DRJ is stable. And I would submit to you that you might, if you're not having good success with the debridements, you might consider doing the thermal treatment, because I do think that kind of, I like to say, caramelizes or basically melts the edge. It's like, sort of like having a frayed piece of rope, you know, it tightens up those frayed edges. So that helps that, and also potentially it denervates that tissue. So I pretty much do it on all my debridements. I shave it, get it relatively stable, and then I just sort of take the device and just sort of treat the edge a little bit more.
Perfect. And then my second scenario is relatively equivalent, and I see a fair number of patients with partial SL tears. They don't have any widening. They definitely have reproducible pain there. And my algorithm for that has been to go in, clean it up, and depending on how loose I think it may or may not be, I'll sometimes pin the SL and the scaph and another pin to the scaphocapitate. Do you just treat all of those with thermal shrinkage?
Yeah, so I kind of blazed through that slide, the Geisler classification, but basically for my stage 1, grade 1 and 2, I basically just do a debridement and thermal shrinkage. Okay. And then when it gets to the grade 3, where I can get something bigger, like the cannula for the scope, for example, the trocar for the scope, if I can get that in between the two bones and it opens up, but it's not a true drive-through, then I'll add the additional pins. But I've been really pleased. I know dorsal central wrist pain is sort of the bane of a lot of people's existence. A lot of people don't like treating that, but I love it because I think this works well. I don't know if it's the debridement, I don't know if it's the mechanical shrinkage or the denervation or a combination thereof that helps them, but these patients get better with this technique. And so so for the lower grade, I just do the debridement and shrinkage. For the higher grade, I do the shrinkage and the pinning. And then I'll throw in there that capsule ligamentous capsulodesis that I showed with that Matulin described. I think that's really useful, particularly for the grade 3. That's really useful because the ligament's still somewhat intact, and so you can get a good bite of it. He uses it even for the grade 4, which I think is a little bit unbelievable, but how well those patients do that he's published on. I haven't had the guts to do that quite yet, but for the grade 3, it's a really nice technique.
Good. Thanks.
Sure.
Well, Jeff, thanks so much again for a phenomenal talk, and I think it's a fantastic addition to our video series, because I think this is the kind of talk that I can see surgeons all over the world referencing and coming back to when they have a case coming up to refresh, if you will, their memories on the tips and tricks. So thank you so much for that.
My pleasure, Bob.
And yeah, I know today's kind of like a Friday because it's a long weekend coming up. So please enjoy your long weekend. Say hi to the family for me, and I hope to be able to see you again in person soon.
Sounds good. Thank you, everyone. Stay safe. Have a great holiday weekend.
Great. Thanks, Jeff. Take care.